Go ahead,
Hi, I'm
Doc.
Dr. Paul Christo, and I'm an associate professor of anesthesiology, critical care medicine, and pain medicine at the Johns Hopkins University School of Medicine. I'm here today chairing Pain Care for Primary Care inaugural conference here in Orlando, Florida. I'd like to give you some tips about typical patients that you might see who have low back pain who could be referred to us, that is interventional pain physicians, for diagnosis and treatment of that particular condition. And let me start with low back pain that may be due to shooting leg pain. That is, if you have patients who have disc herniations that cause back pain, that cause leg pain versus back pain, that is shooting leg pain or radicular pain, those are good patients for the treatment of epidural steroid injections. These injections have been found to be useful for short-term pain relief, that is 6 weeks to 2 months of relief if they have leg pain greater than back pain. If you have patients that you see who have low back pain primarily below lumbar level 5, that is in the buttock region or in the posterior thigh, those patients may have sacroiliac joint pain. And diagnostic injections of local anesthetic into that particular joint helps diagnose the condition. And further, if patients respond to those particular blocks, we can follow that up with a denervation procedure of that joint. And there have been a couple of studies that have shown long-term relief, that is 3 to 6 months of relief after a procedure called cooled radiofrequency denervation of the nerves that supply sensation to that sacroiliac joint. If you have patients who have low back pain that's paraspinal, not central, but paraspinal, those patients can have facet joint pain, either in the neck or the low back. The best clinical correlate actually is not an exam finding, is actually just paraspinal tenderness, rather than any particular provocative maneuver that can help diagnose the condition of facet joint pain in the neck or the low back. We perform diagnostic medial branch blocks. Those medial branches supply sensation to those joints. If patients respond to those blocks, we can follow that up with a denervation procedure. And those denervation procedures have been found with evidence-based support to be useful in terms of longer-term pain relief in the neck or the low back. If you have patients who've had spine surgery and have persistent back pain and shooting leg pain, also known as failed back surgery syndrome, those patients can be candidates for spinal cord stimulation. So think of it as a pain pacemaker for the spinal cord compared to a cardiac pacemaker. These devices actually can be useful, according to the literature and according to clinical evidence, for shooting leg pain, especially after patients have had surgery of the spine, lumbar spine in specific, and who continue to have back pain and shooting leg pain. These devices are placed on top of the epidural space, use microdoses, tiny doses of electricity to stimulate the spinal cord and reduce the transmission of pain from the spinal cord to the brain. Think about those patients that you have then not only who have failed back surgery syndrome, but who have other conditions, like complex regional pain syndrome, for example, perhaps post-herpetic neuralgia or persistent shingles pain, or even intercostal neuralgia. I mean, these are the patients whom we've found can benefit the most from a spinal stimulator device. And finally, if you have patients who have intractable cancer pain and who are not benefiting from oral opioids, oral therapies, or transdermal therapies, think about an intrathecal pump. These pumps deliver tiny doses of medications like Dilaudid, like morphine, like local anesthetics, directly to the spinal fluid and bind to receptors in the spinal cord to reduce pain. So if you have patients who have cancer that's intractable, it's not getting better, think about the use of an intrathecal pain pump. Send those patients to us for a trial. If you have patients who have bad spasticity in their legs, from spinal cord injury, for example, from multiple sclerosis, or from post-traumatic brain injury, these patients too can benefit from a pain pump in which we use baclofen in tiny doses that can bind to receptors in the spinal cord and ease the suffering of horrible spasticity and rigidity. And if you have patients who have had quote-unquote failed back surgery syndrome, that is, they've had spinal surgery in the back, and the pain does not get better or it gets worse, either back pain and or shooting leg pain, these patients too can benefit from an intrathecal pain pump delivering various different medications. You know, I and other interventionalists appreciate the time that you spend diagnosing patients who have pain and treating them, and I hope that what I've given you, just a couple of tools, tips with respect to procedural interventions you'll consider in those patients who have low back pain. Thanks so much for your time.